Prinanda. Hi everyone. My name is Fadili Magia. I'm member of staff within Hub Cymru Africa, as I said earlier, and I work for Sub-Sahara Advisory Panel, which is a network of African communities here in Wales. Hub Cymru Africa, if you don't know Hub Cymru Africa yet, is a network of development organization agencies working in Sub-Saharan Africa, and providing training, support, networking events for the sector here in Wales. And so thank you everyone for taking part in this session today. We've got three amazing, interesting speakers who will be able to share their knowledge, their understanding of COVID-19 in Africa, and possibly what we and the groups here in Wales can do. And I guess we have some people who are joining us from outside Wales as well. And what we can do, what things that can be done to support some of the partners and the groups that we work with. I'm joined today by two of my colleagues. So we have Claire and Kath, and sorry, Claire and Beth. Apologies, Beth. Who will be helping me with this session today and will be contributing as well, should you have any questions or anything that you want to ask. Just a few housekeeping rules. We are running a little bit late, as you can imagine already. Two of our speakers are waiting to come in and join us on the Zoom. But it would be great if some of you could write. I think I see people have already started doing this. Basically writing their organizations. There's a chat bit on the bottom of your screen. So if you click chat, and then you can see the message going to everyone or to selected people that you want to send a message to. So if you do for everyone and say the organization that you represent and maybe where you work ideally. So it kind of eases communication and us knowing who is on the call and who is working where, and if there are any links as such. Just to let you know that also this session will be recorded. So if you would not like to be recorded or your face to be seen on some of our publicity material, then please do let us know. Let myself, or you can tell Claire or Beth, especially on the chat message, you can use that to send a message. So please do let us know. As I mentioned earlier, you can switch your video off and the mic off as well. Ideally, especially when people are talking, it'd be great if you can have your mics off to avoid any interruptions. As we go along, there will be people with questions to the speakers or to some members of staff within Hub Cymru Africa. Please do drop those questions on the chat box. And later on, one of my colleagues, Claire, will be able to summarize them and forward them to the speakers. And also at the end, we will send you a link for you to give us any feedback in relation to the session today. One thing I may say, you have to bear with us. It's a new ways of working, it's technology. So if there is any glitch, please do bear with us, and we should hopefully be able to sort it out as soon as we can. The session today is really looking at how there's a lot of messages to do with COVID-19 in Africa. A lot of African countries have different ways of dealing with the virus. Some are in lockdown, some are not in lockdown, some are in partial lockdowns. So we have to understand that each country or whichever organization that you, or whichever country that you work in, there's different strategies that are taking place, which are making it even harder for groups to know exactly how to support some of the partners. And so some of this, the session today is really looking at how in different modalities and different ways of how countries are working, how else can the Welsh organizations support the partners, or even those who are outside Wales can support those partners in the countries they work in. And to begin with, we have Dr. Zed Sibanda, who is a pediatrician here in Wales and also involved in an NGO called Zimbabwe Health Support Network. he's going to give us a slight picture of the health sector, maybe in various parts of the continent right now, imagining what the challenges they might be experiencing. One thing we wanted to do was to potentially get someone who is a health worker within the continent to speak on the day, but unfortunately we haven't been able to get that. And a lot of health workers are not really, obviously are busy trying to deal with the issue, but also most of them have been told not to speak. And the information we're getting, or the people I have been speaking to, they're saying the information about COVID-19 will only come from the government. And so it's only down to the government institutions to respond to those cases. But in the meantime, Dr. Zed Sibanda will give us a slight picture maybe of what the challenges maybe some of the hospitals and clinics are experiencing at the moment. Over to you, Zed.
Right, I'll try and see if I can share my slides. Can everybody see my slides?
Yeah.
Okay. Right. I've got about 10 minutes for dealing. I'll keep an eye on my clock.
Yes, about 10 minutes.
Okay. Right. What I thought I'll do, it wasn't clear, I suppose, before at the beginning what Fadile wanted me to do. I've done a bit of an overview. I'll try and go through as quickly as I can. And then at each level, I'll try and highlight what I think are the challenges as far as I'm concerned. I've joined a number of other virtual groups and some of the things that have come up. I think in terms of just how big the problem is, we just wanted to get an overview. I think all of us are glued to televisions all the time and trying to get an understanding. Anyway, as of this morning, this is the picture as far as the world goes. In terms of cases, we have 2.7 at the moment. This is from Johns Hopkins and the European Center for Disease of Prevention. And in Africa, the number which is quoted is only 25,000. We know that's really a major underestimate, but we know that it's not as big as in other continents. I think it's evolving going to that. And for the the countries that have recorded the most number of cases, South Africa has recorded 3,900, and Egypt 3.8, Morocco 3.6, and Algeria 3,000. All the other countries are reporting 1,000 or less. And in terms of mortality, the number of deaths are the ones in brackets for those countries. And as you know, in terms of world numbers, we are looking at almost 200,000, with the biggest in America of 50,000 and Italy 25,000. In terms of what I think, in terms of what we can contribute, I think I would try and put things in broad categories and try and say, what can we offer in terms of things? I think one of the things that I think we can offer is in terms of actually understanding and knowledge. But a lot of this information is out there. But every time I talk to people, I hear people that have been reading some little website somewhere. So I think it's useful to emphasize to people that they should use good, reliable websites. I'm preaching to the converted, so I'll go quite quickly about sort of facts that everybody knows, and I suppose people can read for themselves. If there's something specific that people want to come up with, then I can go back and we can discuss that. We know about this, it has come up again and again in terms of the disease and how it is and the things that people look up for. How does it spread? I think we all know exactly all the things that have come up. Really, it's a contact with person to person, and mostly from cough and sneeze. But I think there's a big emphasis that we know that you can get it from touching items as well. We know that it's a very democratic disease, and it has affected everybody from the poorest, including our Prime Minister as well. So everybody can get it. But it's quite important that not everybody is dying. In terms of prevention, I think I've highlighted the most important things: washing your hands and self-distancing. All the other things are there, not as important. I'll comment a little bit about masks, and then I'll comment about as we go along in terms of roles. I just think in terms of information, we have a role in working with organizations that are producing information, whether they are producing information in terms of leaflets, producing information in terms of the broadcast media, or on the radio, people can access that information and help with that. I'm not going, this is my views. I don't want people to say that this is my views and I read this almost every day. We get updates every day and I'll give you my views, and all these views are different. This is my views in terms of masks. I get asked this a lot about what's happening in Africa. Up to today, we know that some countries have recommended masks. We know there's no good evidence that they are very useful for general use, but I would not advise against wearing them. And definitely you should wear them if you're unwell, or especially if you're coughing and sneezing. And if you ask, do I wear a mask when I'm going up and about? I don't, but I'm not saying you shouldn't. And in terms of what can we do, in the key areas of washing hands and self-distancing, those are the main things that I think I've highlighted in terms of, as NGOs, what can we do? Because we all have small organizations and we all do different things. There's a big role for us in terms of PPE, in terms of gloves, cleaning materials, whether it's soap and things like that. And really, there's a big area in terms of masks where there's a lot of people that have started trying to get materials to sew masks and things like that. We really, in Africa, people can't afford buying masks. So I think there's a big role for NGOs in terms of doing that. We also know that COVID-19 is going to kill a few people now, but a much bigger group will die from lack of food and from sanitation. And there's a big role for NGOs to have boreholes and providing water so that people can wash their hands. There's no point in telling people to wash their hands when there's no water around. So a lot of all that is quite important. In terms of health professionals, we know that there's a lack of health professionals at every level, in terms of public health, in terms of diagnosis, in terms of telemedicine. Some of us link up with other groups when we are discussing all these things. A lot of information in terms of management is all in the public domain, but there's a lot of other things that people are sharing of things that are working. And I think there's a role for groups and charities to share good evidence in terms of what's working. And we know in issues like oxygen concentrators and things like that, they're essential in terms of how they can be used. Treatment, I think it's very important for people to get credible information from us. There is no specific medicine to prevent or treat coronavirus disease. And I've checked as of today, there isn't anything that we have which has been tested which shows that it works reasonably well. There's a lot of things that are being tried and which are being tested. A vaccine is the most likely answer. But we know that supportive treatment and in severe cases, oxygen is very helpful. I know in the West, we talk a lot about ventilators. We just can't afford ventilators for Africa. One ventilator will cost at least 15,000 plus. There is a huge role for people that have a reasonable amount of money for less invasive ways in terms of oxygen and what we call CPAP. And we know with the triage that's happening a lot in Wales that a lot of people who survive don't need to go on ventilators, but need to get oxygen and other things. And NGOs can look into that. And there's a lot of innovative things that have been done before for CPAP for children, which can be done for people that can make a big difference. We know the people that die, and it's the old, but we know it's people with additional health problems. And we know in Africa, there's lots of people with additional health problems, including things like hypertension and particularly malnutrition, HIV. I know some people have got access to HIV, but not everybody's got that. My alarm is saying I've got only 2 minutes. There are no drugs so far, we know, that work. And even the ones that are promoted by the big president, I think we all have to be quite clear that at the moment, there is no drugs that have been shown in any trials to work. There is many trials that have gone on, including with chloroquine, remdesivir, and there's a lot of good trials going on. And if the evidence comes up, then I think we should be able to do that. And we should be able to share all this information. Some of us have been disturbed by a few countries in sub-Saharan Africa that have already incorporated some of these drugs on their essential drug list before the evidence has come up. And some of it, people have run out of medication for malaria, which is supposed to be useful for people, and people are dying from malaria before they die from COVID. just to end, I always say, please beware of fake news. And there is a lot of people that know a very prominent, trusted friend or an eminent doctor who knows a lot about COVID. If there's good information, I'm confident it will become public knowledge. And there's all sorts of other things that come up, but most of this is definitely not very helpful. I know my time is up. I just wanted to finish this slide.
You can expand it to 2 extra minutes, Dr. Z.
Okay. There's somebody who's, I think, there's a lot of feedback from somebody who's not muted his screen, I think.
Yes, please. If you can mute all your mics, please, if possible, to ease communication. Thank you.
But this is, we have always known in Africa that these are the biggest challenges, lack of good leadership. And for something like COVID, which needs very good public health, unless you're very consistent good leadership, we have seen it a lot as well in the West where leaders have been doing badly. We've seen places where things have done very well, like in South Korea, and we know that that works. And wherever we can in terms of NGOs, and we've got a voice to advocate, I think we have a big role to be able to do that. I think I'll stop so that I suppose if people want to ask questions, or we can leave questions when there's a general discussion. I don't pretend I'm an expert on all this, but obviously we every day we get updates, we discuss this, we have got cases on the wards that we deal with. I think I put myself, I'm working as a pediatrician. The other thing, obviously, for children, I think for anybody with children, COVID seems to be sparing children a lot. So I think that's a very, maybe a silver lining to some extent. We are getting cases, a few cases, but at the moment, most of them are doing well, and most of them tend not to end up with severe disease.
Thank you so much, Dr. Z, for this brief overview of some of the challenges. What I was actually intending of doing earlier was actually having an overview of the situation in Africa at the moment. Sorry, someone has got the mic on. The challenge, yes. So I wanted to have an overview of what's the situation of COVID-19 in Africa right now. And Dr. Z has given or highlighted some of the challenges that we're experiencing, or the continent is experiencing. To go ahead with the conversation, I would like to invite Beth to give an overview of the situation currently in various countries in the continent. So Beth, give us an overview, please. And then I'm glad to say also that we've got the 2 speakers to join us from Liberia and Central Republic of Africa.
Great, thank you very much, Billy. As Billy said, this is going to be a very brief overview of the information that we currently have on Africa. Again, I'm sure there are people who are far more expert on this call than I am, but it's just to give you a sense of what information is out there. So as of the last briefing from the African Centre for Disease Control, there's been a total of just over 23,000 COVID-19 cases and just over 1,100 deaths, and these have been reported across 52 African countries. This is an increase of 54% on the previous week's report, so it's going up quite quickly. The 5 countries in Africa with the highest cumulative number of cases are Egypt, with 14% of all cases in Africa, South Africa with, again, 14% of all cases in Africa, Morocco 13%, Algeria 12%, and Cameroon at 5%. So as you can see, it's quite heavily focused in North Africa, with the exception of South Africa and Cameroon. 13 countries are reporting case fatality rates comparable or higher to the global average, which is 7%. Those are Algeria at 14% of fatality rate, Sudan 11%, Egypt 8%, DRC 7%, and Burkina Faso at 7%. So again, some higher than the global average, but others that aren't. Oh, okay. So this is a useful link for information if you're looking for information. So this is the, as I mentioned before, the Africa Centre for Disease Control, and this is linking through to their live website. And hopefully, if I can scroll down, you'll see that they've got a dashboard on their front page there that shows, as you can see, the number of cases has gone up since the information I last had. And it gives you a hotspot map of all the countries in Africa, which if you click on, I've clicked on Djibouti, it will give you the number of cases and number of deaths and number of recoveries for each country, and tests and other statistics, which is quite useful. It's also got a regional bar graph in terms of the number of cases. Again, as you can see, high concentration in Northern Africa, and less so going down to Central Africa. It's also, again, got a chart on the deaths by region, and the number of recoveries by region, which is useful. And again, country-specific data, if you click on the country, it will highlight in the dashboard how many recoveries, how many deaths, and how many cases there have been in that country. So this is a good source of information. At the end of the webinar, we'll also be giving out other resources and places that you can look for information going forward. So like I say, again, very brief overview of the cases in Africa. So in terms of predicted impact, the expectation is that if no restrictive action is taken, that the pandemic could result in 2.4 million deaths across sub-Saharan Africa, and this could be reduced by half with lockdown measures, etc. Although a smaller proportion of the population in Africa is elderly, which is, you know, obviously the message that we're getting over here, that the elderly are one of the most vulnerable groups. Obviously, in Africa, there are a lot of multi-generational households, so it is potentially a lot more difficult to shield them from the spread. And there's also obviously other vulnerable populations that perhaps aren't as big as they are in the UK, such as those suffering with HIV, TB, malnutrition, and other health conditions that will make them more susceptible to COVID-19. There's also obviously the health systems are often not perhaps as strong as they are over here, and this could result in a higher mortality rate because the health systems aren't able to cope. The last thing I wanted to highlight was, you know, obviously all the measures that we're putting in place over here are less realistic perhaps in the developing world. And this is a quote from a doctor in India who says that social distancing is a privilege, and that, you know, hand washing means that you've got access to running water, etc. And staying at home means that you've got a home to live in and to isolate yourself from your community, which again isn't always going to be possible in more densely populated environments. So that's my short presentation. I guess if anybody's got any questions, or we can take questions at the end, if that's helpful.
Yes, thank you, Beth. Thank you so much for that. So we just had an overview of what's going on across the continent, and I guess some of the resources where people can go and look at figures and statistics in various countries. And Dr. Zed has given us an overview of some of the challenges. And please do keep on writing your questions on the chat box. At the end, we'll be able to forward those questions to relevant people. So please keep dropping them as you keep hearing from the speakers. And now I would like to introduce Dr. Mama Ann Ogbigbo, who is based in Central Republic of Africa. Ann has experiences of working in Liberia and Sierra Leone during the Ebola crisis, and has a good understanding of some of the mechanisms that worked during the Ebola crisis, especially working with communities in those two countries. And she'll be able to share her experiences of what happened during the Ebola crisis and how they were able to mobilize communities during that time, because it's kind of similar to what we're going through now within the continent, where the spread of the disease is everywhere, and there are different measures, whether it's a partial lockdown, it's a full lockdown, but a lot of information needs to be communicated clearly to communities, and there's a lot of lessons to be learned from the Ebola crisis, and Anne will be able to share some of these things as well. Over to Anne.
Okay. Good afternoon, everyone. I'm talking to you from Central African Republic. Can you hear me? Everybody's hearing me. Okay. So as Fadili said, I work in Liberia. To give you the context in which I worked in the Grand Cape Mount, which share border with Sierra Leone. And the country was like 80% Muslim and 20% Christian. And what really went well when we were there is because the governor put in place what he called task force in each county. They had one at a national level, and they had one at a county level. And at the county level, the task force was composed of all of the traditional leaders, all of the religious leaders, community-based organizations, representative, townships, county local government, and also the UN. And what we used to do is to get together once a week and share information. Oh, by the way, and I forgot, the county health team was a part of the county of the task force as well. And what we would do is to get together and share information. What really worked well was a community, how do you call it, a social mobilization. We had to work with the people at the ground, at the grassroots level, explaining what was the importance of not obeying the measure put in place by the government. The reason why I'm doing this is, like here now, we have been having trouble to put that in place. So we did it, and it worked very, very well. Because what we learned is when the community-based organization representative once they have owned the process, everything worked well. And it's very, very important for the people to know what is the importance of the disease, the importance of all of the like a contact tracing, the case management, in order not to in order to work in collaborative manner with the county officials. And while we were doing that, people who were under quarantine was given food by WFP, which is we don't see that here. Once people are under quarantine, WFP, we ship food at the county level, and there's a county superintendent, we distribute it to the town chief, who in their turn give it to the people under quarantine. And we did also work a lot with religious leaders, like the Muslim. As I told you, the county was like 80% Muslim. We had the problem, like with the burial, they were not supposed to touch the body or wash the body. At the beginning, they used to wash the body and spread the disease around. So we did some sensitization, a lot of sensitization with them. And then they went back to the community and spread the word. And then when somebody dies, they call the burial, the burial team to come in to bury the disease. So these are kind of a thing that we did over there. The issue that we have here, if you don't mind, I give you a bit of an overview of what we have been doing here. I worked with Cyrff. We did some sensitization with the religious leaders and the community leaders in the office here. But what my observation is, people, I mean, the community leaders, the religious leaders didn't own the process. They are like, oh, why the church should not go on, why they should not pray. And you have to understand the level of illiteracy is very high and because the hospital is not well equipped. So people rely on pastors to get healed. People rely on what else? The imam for ordinary diseases, not for coronavirus. So we have been having trouble with them to let it go and refer all of the cases, if there is the cases, to the hospital. So
sorry, this is on corona, isn't it, Maman? This is on corona.
Yes, this is for corona. Yes. So I did some training on it here. So because I try to compare with what we did in Liberia and what is going on here, but it's a very, very difficult. What is really important is to work with the community, sensitization. And once they have owned it, and that they can spread the word around and decide what to happen. Because what at the end happened in Liberia is the community that stopped Ebola. It was not the government. It was the community. Once they decided, okay, enough is enough, they did all they could to stop the spread of the disease. Oh, I cannot see you. So,
thank you.
Yes.
Got 2 minutes.
Okay. What is going on here is they ask people to stay home. They ask people not to walk around. But I mean, there is no electricity. You know, for me to come here, I had to come to borrow an office. People cannot keep food in a refrigerator. So it's going to be really, really hard for them to stay home or not to go out to look for food. So, but if we have if the government put in place a good sensitization program, I think it will work, because it's up to the people to understand and take ownership of the process and see what they can do by themselves.
Is there any sensitization program right now in the Central Republic that you know of?
Yes, we Cyrff started one with 15 religious leaders last Friday, and I just came from another meeting with the government officials, whereby they call all of the mayor, the community leaders to talk to them about the sensitization. But to be frank with you, the process is very, very slow at the government level. There is the issue of a leadership. They don't know how to deal with the issues. And from what I heard, everything is spread around. So I hope that if they can listen to me and accept that I share my little experience with them, what they need to do is to set up a task force at each quarter in a Bongi, to be able to go through the process. People don't have water. There is no running water. There is no electricity. People are poor. So they don't listen to local authorities about the measure put in place to avoid the spread of the disease.
Thank you, Anne. Thank you. I think there are more questions coming right now, which we'll ask at the end of the session. But in the meantime, thank you very much. And I would now like to introduce Abdul Rahman Ba, who is based in Liberia, and who will be able to give us an understanding of what's happening in Liberia. Abdul Rahman Ba works for Life African Mothers, one of the Welsh-based organizations here in Cardiff, and he is their coordinator in Liberia. Sorry, someone's... Abdul, I think it's your phone that's cracking. Abdul, can you hear me? There's a noise background on your phone for some reason. Yeah, that's better. Yes. So Abdul is going to give us an insight into what's going on in Liberia, also looking at some of the community challenges and maybe ways of how Welsh-based organization can support some of the partners in places like Liberia. Over to you, Abdul.
All right, thank you very much. Hello, everyone.
Hello.
Yeah, basically, I think for those who that been hearing about Liberia, Liberia is a little country, just a population over 5 million people. So quickly to what really I want to discuss in this particular meeting or conference is about the community, how we Liberians are managing the disease in Liberia, especially the COVID-19. We have two different systems here now working in Liberia. I think the previous speaker spoke on the community-based system, which of course is very effective. Looking at it from the traditional health system, healthcare takes place in the community, as we all know. They give actual confidence to the people and the patient, those traditional health workers. Patients are taken care of by their family members. In serious situation, they contact other health workers. So basically, the health workers here in Liberia, especially the poor communities, they are not 100% involved in the activities at the community levels. They only play a supervision roles. So most often the community people themselves handle their issues. Only if there's a serious conditions, then they contact health authority. For the standard medical system, the reason why most often patients here cannot actually visit hospital, they complain that it is effective but not affordable. Most of the patients cannot really afford to go to the hospital for care because they are poor. And currently, looking at the current situation in Liberia right now, we have 101 cases, confirmed cases, 20 recover. We have about 8 deaths and 73 stay in isolation. This one can look at it as a progress, but for us, we are worried because most Liberians cannot actually afford their basic needs and food, medication, safe drinking water, house rent. And most Liberians, if this cannot be handled, they might die because they won't be able to afford those kind of things, those basic needs that can actually provide them with safe living. We have a system that is put in place by the government for the lockdown, because we have a 60-day lockdown, and many Liberians live on what we call handout, from hands to mouth, meaning that they work and then before they can eat. So they don't have a basic job that will provide them meal all of the time. So the lockdown starts from 6 a.m. to 3 p.m. Most of them, when they leave their homes, go out there to get food before they can actually get what they need or their basic need. The time already caught up with them. And then they are going back home hungry. And in the health system, hunger is one of the opportunistic disease that trigger down a lot of things. Because once a person is hungry, you experience a lot of symptoms similar to the COVID-19, which is the coronavirus, headache, fever, and other stuff. And also it can also trigger gastrointestinal disease that will lead to ulcer and other diseases, which causing a lot of problems for Liberia. So the previous speaker was talking about aid, like food donation to community, which it happens during the Ebola period. And most of 90% of things that come into Liberia or donation comes through donation to government. The government itself does not have that particular budget or mechanism put in place to actually feed its citizens. So, and most of the places those food used to come from or medication used to come from, we also facing the same problem of this coronavirus. You have a family member who have more than 10 children living in one room. In that particular room, no safe drinking water, no running electricity, there is no food. And then we put in system they call the social distancing, which of course is difficult to abide by with the poor condition of the people. So at this point in time, we have a particular zone that is zoomed out called into 17 zones in Monrovia. And within those 17 zones, one of the most populated areas is West Point. West Point alone have more than 50,000 people. And each of those homes, the poverty rate actually is high because it's a slum community. And many people actually cannot afford to even get their basic need. And the worry now is that when one case of coronavirus appears in those particular hot zones, it becomes a serious danger. And most of the dangers that which of course will occur will be mixed with or be trickled down by poverty because of their condition they live in. So Liberia at the moment is on a time bomb. Many people will die if they don't have the food and safe drinking water with medication. So the coronavirus is on the other side, but equally so, what people more worry about, because people are washing their hands, carrying on all of the mentioned, but yesterday they cannot actually get the actual food they need. So with that, the government promised to make some allocation of food and other medical supply, but up to now, there is no indication on when or how those distribution will be. With other African countries, probably we have the similar story, but there might be some difference in terms of affordability. For Liberians, just the 8 deaths that we are talking about now, most of those people did not die in a hospital, but rather they died in homes due to hunger, although they had coronavirus, but they were hungry and they couldn't afford to even fight the virus. So end of the day, they die at home and then tested before even they can be confirmed. So we have a serious problem. And if international community and the government with that of the local people can work together, I think we can mitigate this particular risks. But without that, looking at Liberia with the current situation and from a public health background, I think there are major issues surrounding this whole coronavirus fight in Liberia than even the coronavirus itself, which is poverty. So if we can tackle most of those challenges, I think coronavirus will be fought easily, especially in Liberia with our experience from the Ebola. So health workers are actually contracting the virus. They are not actually contracting it because they want to or they don't know the procedure, but because the basic equipment they need are not available to work with. People are afraid now to go to the hospitals because people who are to care for them are not actually equipped enough to care for them. So even when they have a malaria, they will be afraid to go to the hospital because they feel threatened that they might not get the actual treatment or they might be infected from the virus. So most of the deaths that will occur over the past time or in a few times to come will not be only coronavirus. For now, even yesterday, I visited one of my friends. A lady died in a house. She was pregnant. She should have given birth at the hospital, But the time for them to book the appointment, the hospital she's supposed to go to give birth was one of the hospitals that some of these health workers died from coronavirus. So she couldn't go there. And then they refer her to another clinic nearby where the staff there were not actually up to the task to care for her, and she has to die. Many more of those deaths will occur pretty soon if things are not actually handled properly. So looking at it from the community perspective, the community are doing their job. People are working towards improving themselves, but they don't have the ability to actually carry out what really needed to be carried out. Thank you.
Abdu, I would like to maybe to start off with maybe just one question where you can share in terms of some of the groups here in Wales and beyond. What can groups in Wales and beyond do to support, I guess, the partners in country or the communities in country?
Yeah, if for Wales, I might not know the actual group that would be interested in helping with 3 basic things: community awareness, food distribution, and at the same time, helping with safe drinking water. They have a lot of water supply companies that are very cheap and affordable that can supply a whole community per week. So, but I cannot really speak to a particular group in Wales. Probably Angela Goma, if she's listening, she might actually come up with some other idea on that. But for Liberia, what is needed now is food, medications, and other basic needs to carry on their effective, to help communities to carry on what really need to be, to help them in order to carry out their basic life.
Can I respond to part of what Abdul had to say? Or
Thank you. Yes, Angela, you may.
Thank you. I'm Angela Gorman, CEO of Life for African Mothers. We work predominantly in Sierra Leone, Liberia, trying to stop women dying in pregnancy and childbirth. And before Christmas, I had the opportunity to meet with the then Secretary of State for International Development at DFID, who was very interested in what we were doing. And I set up a communication with one of the people in DFID to take this forward. And then when the virus started to become a big problem, I contacted them and said, obviously this program is going to have to be put on hold, but does DFID have any plans to provide funds for sensitization in sub-Saharan Africa? And basically what's happened is that I had an email back from this civil servant in Whitehall who advised that our country representatives go to their local DFID offices in country. Liberia doesn't have a DFID office, but they do have a fantastic British ambassador who I've been in touch with. And to cut a lengthy story short, Morlai, our representative in Freetown, has been to the DFID office in Freetown, and they are looking at the proposals that we are putting forward to provide sensitization sessions in the most challenging areas, in the slum areas like Crew Bay, and as Abdul mentioned, West Point, which I visited. So there is money out there for people to apply for, to provide the sensitization sessions. And so we've already started that process now, literally in the last 24 hours, to start, because obviously time is of the essence here. We haven't got time to hang around. We've got to get this going pretty quickly. So David Galgrove, the British ambassador, is supporting us, and he's going to see what he can do. So we have to use all our contacts. It doesn't matter who they are, but we have to use every resource, I think, now available to us to try and get this sorted. Because at the end of the day, if the countries who a lot of people don't think it affects us, but it does. Clearly, when Ebola was happening, I was banging my head against a brick wall saying Ebola is 7 hours from here, and so it's in everybody's interest to try and keep the cases outside of the UK to a minimum, so we can protect our own population as well. So this is an investment, and hopefully that's how DFID are seeing it. So can I suggest that anybody here who is working in a country where there is a DFID office, please contact them, find them and contact them, and put a proposal in for how even something like a megaphone, Abdul knows, you know, megaphone, buckets, hand sanitizer, it's all, and because of the experience of Ebola, Abdul and Morlai are the experts with getting into these communities and bringing an awareness. And Abdul mentioned to me that they have ideas that maybe we wouldn't even think about doing, you know, because of experiences. So I think, you know, in this sense, they are the experts here, and we need to look to them. Just one other
Thank you, Angela.
I had an email yesterday, a message yesterday from somebody senior in the Ministry of Health, John, who sent me a film of, and I don't know what the answer to this, but in Guinea, 2 supposedly French doctors went in and to give injections, vaccination supposedly to children, and they gave them to 20 children. I presume they were being paid, and clearly they were frauds. Within an hour, 2 children had died because of what they had given them. I just wondered, what is the best way to get information to people about the fact that A, there isn't a vaccine yet, and how can we communicate with people in the communities to say, if somebody comes in with this type of information, that they are not to respond positively to them. I don't know what the answer is. I'm just asking people in the countries, you know, in our partner countries, how do we help with this? Because it's just a tragedy that these people are taking advantage of this situation and going in and making money by offering vaccinations to children, and they're dying within an hour. I don't know if anybody has any ideas, but sorry to go on a little bit, but I just thought, as far as DFID is concerned, there are resources there, and if people do have contact or can make contact with DFID, we need to get on to it pretty quickly, which we've done in the last 24 hours.
Yeah, there's a lot of information on WHO's website. Yeah. And I think there's quite a few materials that are printable to be shared in communities and translated in different languages as well. So WHO might be a good starting point.
Print it off, don't you, in the country?
Yeah. Later on, Beth, one of my colleagues, she will be able to share some of the, like a resource page with different links so that you can find different information about various things. Okay. Whilst you're on the call, Angela, you did ask a question to Dr. Z.
Yes, about the issue of testing, and that in theory somebody, Dr. Z has actually replied, but basically it was negative today, and be exposed to the virus tomorrow, and then they become affected by it. So it's about the value of testing for non-clinical stuff, for people, you know, because there's this big thing about people being tested, but I wonder, because for a lot of the population, there wouldn't be any point really, apart from knowing the prevalence of it, and where people have got better, that they haven't needed hospitalisation, whether we should prioritize the testing equipment that we've got. And of course, there are false negatives as well, so it was just...
yeah, and is it possible for Dr. Z to respond and everyone can hear?
Just looking for the... It's the healthcare staff and whether or not they can go back to work if they are... That's the value of them rather than the general population.
Yeah. Zed, are you able to add to it?
Somebody added to it.
So the speaker, the mic is, you need to switch your mic.
Oh yeah, sorry, I put my mic on. I think we know that there's a good role in testing to understand where things are. And obviously, because of the capacity and the lack of testing ability in Africa, you have to be able to target it in a certain way. I think the specific question was that to try and see, particularly for health worker and key workers, where we find it most helpful. I think if you've got a very limited resource, maybe you've got doctors, you've got nurses, and they've got picked a little bit of a cold, and that could be COVID-19, but actually it might not be. So to know that they are negative is very important so that they can get back to work.
Yeah.
And obviously, if there is capacity provided probably by WHO to try and understand the dynamic in a country, then that's a much bigger question. But most governments don't have the capacity to test. The figures that we are giving you of 25,000, it's clear that it's probably 10 times that, but a lot of that is because there's no capacity. The issue related to antibodies, I think, is an evolving picture. In the long term, I think that's going to be extremely useful. At the moment, it's not yet widely available. We still don't quite understand whether it's reliable or not, because there's still questions about in terms of what sort of degree of antibody level would be protective for you not to have done. So until that question is answered, I can't comment too much. So their usefulness at the moment is limited.
Thank you, Zed.
Thank you, Zed. Thank you. Just to remind you that this is just a platform for us to share any best practice or good practice that you might have, but also to share information. So if you do have anything that you would like to share with the group, please do add on the chat. You can also send us an email, the Hub Coming Africa email address, and we'll be able to share any resource that you're sharing. There were a few questions from participants, and I think my colleague Claire has got a few, is going to read them out, and they're directed towards the speakers.
Yeah.
Claire?
Thanks, Fadili. There haven't been too many questions, but there have been some interesting comments made in the chat box, which we'll endeavour to share after this as either a blog or a newsletter potentially, because I think there's some good sharing. I thought one of the points that's quite interesting, and I think it's come through on a couple of comments about kind of local responses, and that trust in politicians is quite low. So how do we deal with lack of trust in politicians, and how do we ensure that people aren't seeing coronavirus as a mechanism to stop people from going out voting or disputing positive results? So I think that was aimed probably generally, but I don't know if there's anyone on the call who has experience of building trust around messaging. I guess some big organisations like WHO and the UN probably have a role in some of that as trusted sources. But I think that's quite an interesting observation. I'll hand to Fid.
Thank you, Claire.
Hello, can I?
Yes, yes, Anne.
I just wanted to. Yeah, I just wanted to intervene. When she talked about trust is very low in politicians, local politicians, I agree with that, because when we had Ebola in West Africa, WHO and UN and the African Union sent experts on Ebola to come and work with the government, and so they had the know-how. But with this case of coronavirus everywhere, it's very difficult for other people to come and work here. I don't know if the government did put a request for that. So at a local level, they have not dealt with this kind of a disaster before. So the response is very, very slow. And I think the government need to call, to ask WHO to send an epidemiologist, to send a specialist in the field to help them, which they are not doing. And I feel like there is a lack of proper channel of information. Like here on the ground, until today, the country had like a 17 confirmed cases, but we don't know how many people these confirmed cases have been in contact with. They publish 800 something, but it's difficult. It's difficult.
I want just to add something. I think about the question, the lack of trust the politician. I work myself in WHO. an immunization program as a secretary and dealing with the communication. And one of the big problems we need to deal with in DRC by that time was really how really to pass the information of the poliomyelitis vaccine to the community, because as now, we know that in Africa now there is a kind of anti-vaccinations message turning around people, and how really we deal with it. And what our friend from the Central African Republic said, that was the approach we adopted in DRC by that time. It was really to try to pick up some people on grassroots, some not only the religions leaders or some key persons. And I think on this period of lack of trust of politicians, I just came back from the DRC 1 month ago and passed by Addis Ababa. You can see the difference between Ethiopia and DRC. In DRC, we got election, you know, yes, 1 year ago, but no one is a trust to politician there. So, and now the problem is we need to identify in those communities some key people, and is it possible to identify that? I was invited in the national television, and I said to them something ourselves. I said, probably from the diaspora, we need to have a kind of good overview of good people who can work with us. Also, people from back home, they don't have also a kind of good link with the good diaspora organization. I mentioned about Angela organization, for example. This is the organization is delivered straight to the, you know, the need, people who need. They are not, you know, given to the government. I say, is it possible to build this kind of link? So now, because we have this big challenge, I think is it possible to identify where you are working, some key people who can become really kind of, you know, task force of, you know, information in both sides, not only to communicate to them the best information we receive, but also to have from them key information from, you know, what is going on. I think this is the best way to do it now.
Thank you, Norbert. Thank you, Norbert. I'm just going to read one question. Claire, have you seen the questions? Are you able to share?
Yeah, I am. There's two questions that came on almost simultaneously about the same issue, and it's mainly for Abdul. People are interested to hear about how markets and food supplies are being affected. So if you have money available, are you able to buy food, and are markets open? Is there any, can you give us any comment on that, Abdul?
Yes, thank you. Yeah, food places are open. Yeah, when there's funds like 125 kg of rice is $15 US dollars. Yeah, so food is available in the market and it's open from 6 to 3. And coming back to the trust issues, yes, how are we dealing with trust in Liberia, which of course our government is not actually trusted. But what we learned from the Ebola process and that of HIV and AIDS, what we did is that people that are killed from those diseases, they are from the communities. So what we do is that we use those same people to come up within a community and explain to the people the processes for which and how they got it. And one of the things that we are doing is that we preach certain health law in order to carry out. One of it is the confidentiality, meaning that we shouldn't say someone's name.
Sorry, continue, Abdul.
I think he's saying it's frozen.
I think probably got a connection problem there. Abdul?
Yeah, yeah, there. Sorry, I got it. Sorry. So we call their name and then they're able to provide information that can help the communities, because then people will believe them because they are from the community. They will believe that they won't lie to them because they are from the same community, and then they won't.
Sorry, a bit of a technical glitch there. Claire, were there any more questions?
I have a question.
Go ahead, Amertha. Sorry, we were gathering questions in the box, but go ahead and ask a question.
Yeah, it's about the analysis from the Sky News actually, concerning the BMA group dying at the level of 70%. Most of them healthcare workers, both in England and Wales. And basically, they are dying massively, so to speak. And I'm just a bit concerned. Obviously, I'm from the same group, like most of us. So I'm just wondering, why should BMA group really work in these sectors, dying at this high level? Any doctors here maybe to tell us any reason why specifically BMA people, or is it because of antibodies? Is it because of any other reason? I really don't understand, because the same thing is happening in America at the moment, and I'm just kind of worried, why is this happening?
Is the question is slightly out of context with what we're doing with the international.
Sorry, I joined in late.
But I think maybe later on I can connect you to Dr. Zed to give you a more in-depth answer to that.
All right, sorry about that.
Yes, no, that's absolutely fine. Absolutely fine. There was one question to Anne, I think, regarding food as well. If there are any challenges. I know in some places food prices have gone up, and I'm not quite sure whether this is in Liberia and as well, or in Central Republic. I don't know if Anne, you're able to share your experiences on that.
I think the food problem is everywhere.
Yeah, so even the onion comes from Cameroon. Onions come from Cameroon, and the local food come from the countryside. And since the coronavirus and trying to limit movement of people around, the price of the food has been gone up. You know that the 50 kilo of rice, who used to be like 11,000 sefyllfa, went up to 26,000 sefyllfa. Just to give an idea about how the prices went up. Everything is very, very expensive. And the purchasing power for the people is very, very low. So yeah, there is a problem.
Thank you, Anne. There's another question too about, so I'll read it out. It said, what about community health workers? Have they been incorporated into the response? Are there guidelines available for them to follow? I think this is directed to Abdu. Are you able to respond to that? It's community health workers. Have they been incorporated into the response? And are there guidelines?
Yeah, there are some, to some level, the community health workers have been incorporated. And the guidelines, yes, we had guidelines, previous guidelines to work with. So we are actually building on from the past, lesson learned to combat this coronavirus. That's the reason why you are seeing that the case of the coronavirus in Liberia is increasing, but in a moderate level compared to what was expected. So, but the major challenge all over have been their basic need.
Thank you, Abdu. Claire, was there anything else?
There's not much else that hasn't been raised or discussed as a theme amongst the discussions. We've talked about the antibodies, we've talked about food supplies. There's a discussion here about mass sensitization, which Beth has kind of spoken to. But I don't know if there's anyone who would like to speak more about how the sensitization of community seems to be a key thing that we need to be working on, and do we have experience of the best ways to get the messages across to rural communities? Beth has mentioned how effective radio is, and I guess on the ground communication with megaphones. Messaging through mobile phones seems to be a good way of doing it, so kind of through WhatsApp. I suppose one of the challenges with that is to prevent or to do some myth busting to make sure true messages are getting through, because I know that's a global problem, kind of hearing incorrect information. I mean, Trump did suggest we disinfected ourselves with bleach last night, so I don't know how we're supposed to myth bust with hearing things like that through mass media. Is there anyone on the call, I guess, who has specific advice on sensitization and would like to raise anything they've had good experiences with?
Mm-hmm. Okay, what we did in Liberia during Ebola outbreak, as I said earlier, we included everybody in the task force at the county level. So when we come to a meeting, if there is they give us information about what is going on in the villages, and a team, and the county superintendent and the team of NGO, they will put a sensitization program on the issue. If it's a issue on a burial, they will put something on a burial to go and sensitize people with. And I think that with all of the, like here, with all of the, like in French-speaking countries, they have a chef de quartier, they have a city mayor, they have a quarter mayors. And I think that if all of them get involved and they have at a village level, at a traditional level, you know, the way to pass the message, where the village choir would go around and in the evening and in the morning, you know, talking to people. And I think if we can do that from each quarter to quarter with the town chief, it can bear fruit, because these people, they know their environment, they know who lives there, and they can go in the morning, talk, and go in the evening, because all of the chefs have what the chief quarters have what they call village criers. So we can use also the traditional way of talking to people, of sensitizing people, which is not supposed to cost too much money. You see?
Could I just respond to that? With the coronavirus, the last thing we want to do is bring people together in large groups such as choirs. We have to maintain this social distancing. So I'm just wondering, you know, how we sensitize people without bringing large crowds together. And I think somebody's responded about radio and other messaging. So I was just wondering if, you know, in terms of Ebola, how you managed to get the message across without bringing a lot of people together in close proximity.
Yes, maybe Abdu, you can respond to that.
Thank you. So we actually use like the microphone is one of the best thing we do. Someone get in the community and then pass around with a microphone, informing the people about the actual measures. Or the PA system, get in a vehicle with a large PA system, stand to a junction, and then play the jingle of what really need to be done. And then local radio stations in various languages, because we have 16 different languages in Liberia, which we call it dialect. And then we will put it in those traditional dialects, and then each and everyone will listen to it, and then they will actually get the message properly. So we actually been doing that. So, and when you look at the issue pertaining to the mouths, nose mouth, this gone week, the Ministry of Health, in partnership with the Public Health Institute, came up with compulsory nose mask wearing. So everywhere you go, you have people with their masks, except me now because I'm alone in. So people are putting their masks on their faces everywhere they go, to public places and what have you. So it's actually working because it's compulsory and been put into law until they can announce the coronavirus free. So with assessing the mouse, someone might ask, how do they assess it? So what is done is that one of the things that we are going to do is that we are going to buy a fabric that is not used in places, so on. Desensitize it, prepare it with the nose mouse, and then people then can be, we give it out, and then we sell it for little of nothing so that they can value it. And then those women who will be preparing them will actually have another way of sustaining themselves. So we have a range of programs that we are putting together so that people can be able to afford. A lot of people are home. They are seamstress, they can sew and tailors. So they will be able to carry out that particular job and then distribute in a community from house to house.
Thank you, Abdu. Any further questions at all?
Norbert asked us a question, and I think it was probably directly aimed at Hub Cymru Africa, about whether we can put people in touch with DFID offices in country. That's something I'll go away from this call and investigate. I don't see that it should be a problem. I think DFID are operating in a slightly different way at the moment to kind of get to communities with less barriers in the way. Leave that on with me, and I'll find out off the call. Ali also spoke earlier on in the call about fundraising and doing joint fundraising campaigns for kind of in the same way that happened for Ebola. I co-chair the Wales Overseas Agency group with some other charities in Wales, including DEC, who are the Disaster Relief Agency. Everyone's quite keen to do some fundraising work, but there's just a certain amount of nervousness at the moment about about how it would be received, because we've seen a couple of other organisations have put messaging out there, and it's been sometimes received a bit badly when people see kind of immediate need in Wales in terms of PPE and fundraising for the NHS. So we're keen to support it. We're just working on how to do it sympathetically, but we know it needs to happen, and we know there's a lot of support for it. So I'll pick up with Ali outside of the call about that as well, about how we can coordinate something that's successful.
Anything I hear from DFID, I will obviously pass on to Fidili to be shared with everybody. Okay.
Thank you, Angela.
Hiya. Hi, Fidili. It's Jenny.
Hi, Jenny.
From the from now working with the Office of National Statistics. But yeah, a general question, or perhaps could we hear possibly a little more even about the people with the experience of the Ebola response, about how the chain of transmission was broken and how distancing or keeping people away from each other, which of course was surely, you know, one of the key parts of the response, was managed in a way that somehow broke the chain of transmission in the end. Is that what happened? And how was it managed without great detrimental impact on people's livelihoods and ability to move around? And how did they keep themselves fed and in employment, and, you know, during that period?
Thank you, Jenny. If I may start with Anne, maybe if you're able to respond to that at all in some ways or another, in a very short, quick way, as quick as you can.
Which was touch one, touch all. So it means that if you touch someone who has Ebola, you will get it.
So can you go back, because you're muted earlier. So if you can start again, please. Sorry.
Say again.
Can you start again, please? Sorry, because you're muted earlier.
Oh, okay.
Yeah, if you can start again.
Can I start again?
Yeah.
Yes. Well, people were, can you hear me now? People were sensitized about, there was a saying, say touch one, touch all, which means that if you touch someone who has Ebola, you will get it. And when people were aware of it, they took responsibility not to, to do the social distancing by themselves, avoid sitting 2 or 3 on a motorbike, sitting, several people in a bus or in a public transport. So people were sensitized and they took responsibility to do it by themselves. Is that okay?
Yeah, thank you.
Fadili, if I can add just about this, because I was working as a journalist during the second Ebola, 1994-1995 in DRC. And something we probably are missing now. When I came back from Africa, I was so surprising that the serials I've seen in the airports in Africa, I've not seen these serials in Heathrow Airport. It looks like in Heathrow Airport, it was just like the forest gate. You just get out. But if you take, for example, in the airport in Addis Ababa, every time they check everyone, you need to fill the form of where you are from, where you will go, and if you sleep in the hotel there, they will trace you, and everyone is covered. So people, they take things a little bit serious there. And during the first, this second Ebola in the Kikwit area, Dr. Muyembe, you listen about Dr. Muyembe, when he said to us, the first thing is you need to isolate yourself, and they isolate the confirmation of all, this hospital and the people who was working there. This was for 2 or 3 months like this. And everyone became aware. But here I'm very, very surprising when I started listening that people are still arguing about to say they want to walk away, but how really people are not picking up the seriousness of the disease. So this is really, I think, and another problem, I think from this side, I think that our decision makers, ministers, whatever, the thing is that they did have a kind of a lot of message. Yes, no, no, yes, and that's make a confusion. But in the other side, you listen that everyone say the same things. Stay away. Don't say hello. Don't touch to anyone who could have it. But here we have a kind of, and doesn't make it difficult.
Yeah, thank you.
I'm asking if we are not late.
Thank you, Nobe. Thank you. We're just coming close to wrapping up, and I wanted Beth, my colleague, to share one of our slides. Basically, it's kind of a slide with some of the resources, tools that you might be interested in. Over to Beth.
Thanks, Fadili. This we can share in our follow-up email afterwards, so don't feel like you have to frantically scribble down all these web addresses. This is by no means extensive. It's just some of the resources we've come into contact with, and obviously the sort of resources and information available is changing very quickly. So the first one is, as I mentioned before, the Centre for Disease Control, Africa's Centre for Disease Control. There's also a couple of good websites, one called African Arguments and one on COVID-19 in Africa. All three of those have latest case figures and death figures and statistics in relation to the whole continent. Bond, which is based in England, have various resources and various advice and information on their website. Sorry, I should make this bigger so you can see it. And then the Southwest International Development Network have done a roundup of funding available for COVID-19 projects. We obviously on our Hub Cymru Africa news page are regularly posting information and advice, so do check there. And the last thing is there's an online learning platform called Kaya Connect, and one of the learning pathways that they've got on there is about dealing with the global pandemic, and it's one that you can share with your partners in country to help skill them up to respond to it. But yeah, like I say, I will make sure we share these in our wrap-up email, and we will keep adding to it as more information becomes available.
Thank you, Beth, for that. And we're coming to an end of this session. We've had, I think, a very interesting, thoughtful, educational session, and picking up a few things maybe that you weren't aware of and now you're aware of, or some things that you probably knew already. We will continue with the series of COVID-19 sessions, and I will pass over to either one of my colleagues, Claire or Beth, to say when the next one will be and what it is on.
Yeah, so our next session is on Thursday, the 7th of May, and that will be a general open discussion session for people, groups in Wales working in Africa, and it's just a chance to bring the challenges that people are facing, what their partners are asking them for support with. So it's very much a more informal discussion. We haven't got any formal presentation, so it's a chance to chat with your peers and share learning about what you're doing. And then 2 weeks after that, we will have one on distance learning, which Emma is pulling together. Emma, I don't know if you want to say something about that.
Sorry. Yeah, we were looking at distance learning, given that a lot of projects are looking to sort of reorientate their response to that way of working. So I'm still confirming the agenda, but we're looking at, there's an infection control MOOC that Bangor University have run, so I'm hoping that they'll participate. And then there's been some work on food security distance learning as well. And Peter, I think, is on the call. Peter Muckle from Saddleades hopefully will participate. He's been working in that way for his project. So that's the main things. I haven't confirmed the date yet, but I will in the next few days.
Thank you, Beth and Emma. Is there anything anyone wants to comment before we close the session?
No, I just wanted to say that we're also going to run one on COVID-19 and gender at some point after the distance learning one as well, given that apparently the physiology might mean that men are more likely to be affected, but similarly women are more likely to be in caring roles. So just to talk about those kind of impacts. So that's that will be the one after that. So if you have recommendations for speakers, we'd be happy to hear from them. We've shared, Fid, I'm sure you're going to make this point anyway, but I've just seen it pop up on my screen. We've shared 2 surveys, one survey, an English one and a Welsh one, which we'd really appreciate your feedback on so that we can really hone these webinars and make them useful. We'd also be interested to hear if there's a free comments box about times and days of the week that you're more available. I'm conscious it's Ramadan at the moment and Friday prayers happen around this time, so it's not always going to be easy to get to a Friday lunchtime call, so very willing to hear about alternatives. And yeah, thanks to Fid, Beth and our speakers as well for convening this, Fid in particular, but not above everyone else, so thank you. But that's it from me.
Thank you. Thank you, Claire. So that's it, everyone. Please do respond to the monkey survey, and yeah, look after yourselves.
Just a last things. I think you know, going back in Africa recently, and I've been in Africa 5 years ago, I got this impression of double standard of Africa and Africans. And I think we have a job to do. I'm not saying that we are living in a paradise, but to be honest, people are suffering there. People are suffering sometimes on the base, you know, but there is a way also to find solution locally. But you have all our politicians, as you know them. So I think there is a way we need to carry the job we are doing, even a little. I did mention about what Angela is doing. It's a little thing to send those medicine to, but you can't imagine when you go somewhere, you see a lady dying, you know, on giving birth just because she doesn't have an injection, and you question this injection. They say you need to pay $50, and you look $50 for so. And coming about, you know, people are dying about diabetic or whatever. Most of things in this side we just take after granted. So I think we need really to spread the message. We need to help where whatever we can do. Thanks.
Thank you, Nobe. And this is exactly what we're doing in these sessions, because the sector in Wales is about solidarity. It's about working together. And those are our ethos and values. And we very much try to abide and stick to them as much as possible. So if we can't do anything and we can do much, then let's make things happen. And on that note, I just want to say that we will share the slides, we will share the resources that Beth shared via an email, so you get to hear from us soon. And yeah, we look forward to see you on the next sessions. Thank you.
Everybody. Thank